our distinguished group today. And we will go into an overview and background of how we got here, components of the proposed program, next steps, and then we'll devote session to questions and answers. And let me just, a quick reminder at the top here, everything we talk about today and the components that are described in the presentation are all subject to federal approval. So from the American College of Physicians, Maryland chapter, and Dr. Pat Sapp from the Maryland Academy of Family Physicians, I'd like to ask both of them to say a few words. Dr. Sisson?
Sure. Chad, thank you for inviting us and involving the American College of Physicians. There's the old adage about living in interesting times, and we certainly live in interesting times as far as healthcare reform, healthcare finance, quality outcomes are concerned, and we're seeing all of those begin to converge and intersect, and that's actually a very exciting thing. I think the federal government and the state government are both aligned with trying to improve the quality of care that we provide and to do so in a cost-effective, outcomes-based approach. Having any of the presentations of MACRA and total cost of care and healthcare reform in the country and in the state, it's a wonderful resource to have this conversation to get us ready for the Maryland Primary Care Program, which is something that I think is very innovative and exciting, and something that is offered here in Maryland that can help us align our healthcare outcomes in a better way. And so I want to thank all of you for attending today. Just one of many webinars that will be presented on this subject. And as I said, I've heard this kind of presentation several times, and I still learn every time. So we hope to see you at some of these future webinars as well. And with that, I'll turn things over to Pat Sapp.
Thanks, Steve. I'd like to welcome our members to this webinar about the Maryland Primary Care Program. This is really an unprecedented opportunity for Maryland primary care practices. And the Maryland chapter of the AFP has been discussing this for about a year. Our task force on payment and care redesign has been supporting the program. And at our membership meetings in 2017, we've been going over the program in some detail. Now our chapter is helping the state launch a series of informational sessions to prepare these practices as they evaluate this really voluntary opportunity. Many of us have invested in EMRs, we've qualified for meaningful use, we've joined ACOs, we've begun transforming our practices to deliver on population health outcomes. So what's different? I would say to you that the Maryland Primary Care Program offers upfront payment for investments like these and more, rather than having practices wait and see if they can share in savings. So this new program is more deliberate and predictable in its approach to rewarding primary care done well. Really excited now to turn the program over to Dr. Howard Haft.
Thank you. Thank you very much. I'd like to start by thanking our primary care leaders, Dr. Pat Sapp and Dr. Steve Sisson, for their kind introduction and their interest in this program. We always like to start these discussions with the reason why we're doing things and then move to the details of what the program actually brings to you. The simple answer to why we are engaging in this program is that all of us are growing increasingly frustrated over the fact that in the greatest nation in the world, with absolutely the best doctors in the world, we're not delivering the optimal health care to our patients. The underlying issues are really complex, but the result is that the U.S. ranks 37th of developed nations in regard to the quality of its health care, judged by the World Health Organization, and first overall by far in terms of our cost per capita. And we really want to improve on the situation nationally, and Maryland right now is a great place to start in that journey. Over the next hour, you will hear details about a voluntary program, entirely voluntary program, intended to offer primary care physicians across the state the opportunity to gain significant financial support and considerable technical support in transforming the way they deliver care from the traditional fee-for-service, volume-based care to an alternative advanced primary care approach, with the ability to enhance patient-centered care and utilize support resources for issues like behavioral health, pharmacy, care management, and other issues that were previously unattainable in the strict fee-for-service environment, and ultimately to improve the health and lower the overall costs of health care for our patients. The Maryland Primary Care Program is funded by Medicare, but the intention is to transform and improve care for all of our patients. As part of a historic enhanced all-payer model contract between the state and the Centers for Medicare and Medicaid Services, it is totally voluntary physicians and complements the work that our hospitals are doing in reducing unnecessary costs and improving quality. And the next slide, if you can't see this, is a survey. This is each of our participants in this webinar will have their own feelings about their practice and about the future of healthcare. But on this survey slide, you can see the results from a broad national survey done in 2016 by Merritt Hawkins. In the slide, we've highlighted several of the key features in that survey that I think perhaps best describe the way in which healthcare is viewed by physicians currently. And I'll point out, when you see the slide, that Maryland lines up very well with the nation as a whole and doesn't deviate in any significant way from any of the measures. The first measure on the slide really describes how you feel about the future, or how doctors feel about the future of the medical profession. In this, you can see that the majority of individuals are either somewhat negative and pessimistic or very negative and pessimistic about the future of healthcare as it stands today, unchanged, the current unchanged trajectory. Next highlighted form is importantly how familiar you are with the MACRA Act. This is something that's really astonishing to me. This is an act that was introduced to change the way physicians are measured in terms of quality and how they're compensated in that regard by Medicare. As you can see on the graph in this slide, when we survey physicians both in Maryland and nationally, the majority are not very familiar with this act that has major implications with the way that we'll measure quality, how quality is analyzed, and how physicians will be paid by Medicare now and into the future. And the final highlighted section is which best describes your current practice. And as you can see in this section, the majority of physicians are either at full capacity or already feeling overextended and overworked. The situation certainly is not describing a very positive or optimistic or comfortable situation for physicians currently. This is one of the very important reasons why we're presenting this voluntary program, to be able to make improvements in primary care such that we can be more optimistic, we're able to focus on the important things in our practice, and provide additional resources such that we can do those things. The next slide really begins to describe the Medicare Access and CHIP Reauthorization Act, or MACRA, which became the law of the land in 2015 and became effective in January 1st of this year, 2017. This law governs the way in which physicians providing care to Medicare recipients report on their quality measures and are paid for their services. This is one of many in a serial amount of steps the Center for Medicare and Medicaid Services is taking toward moving the entire payment system toward value-based payments under MACRA. Under MACRA, there are two major routes that physicians can use to optimize their quality reporting and payments. The first route is MIPS program, or the Merit-Based Incentive Program. In this program, data on quality metrics is uploaded on a regular basis to tests, and providers are rated as to their performance on selected metrics. Adjustments are then made to their Medicare payments on a range that goes from a negative 9%, that is 9% decrease in Medicare payments, to a positive 9%, depending on the performance relative to the nation. This is one of those measures and payment systems that's designed to have budget neutrality, so that there will be more or less as many winners as there are losers in this, so that the penalties will pay for the bonuses. Medicare fee-for-service payments under the system are subsequently made based on this schedule. The second route, and the one that we favor, is gained by entry into what's called an advanced alternative payment model, such as our intended Maryland Primary Care Program. In this model, qualified providers gain all of the financial incentives that are in the program, which you'll hear about shortly, as well as qualifying for a 5% MACRA bonus. So the specific of the MIPS program in great detail are really beyond the scope of this webinar. However, as you can see on this slide, there is a progression of quality payment programs that begin with MIPS, move toward the advanced alternative payment model. An alternative payment model itself is a payment approach that gives added incentive payments to provide high quality and cost-effective care. APMs can apply to a specific group of clinical conditions, a care episode, or an entire population. Advanced APMs, which is what our Maryland Primary Care Program is intending to be, are a subset of APMs and let practices earn more for taking on some risk related to their patients' outcomes. And in those, you can earn an additional 5% incentive payment by going further and improving patient care and taking on this risk through the advanced APM. In our program, you'll hear about a little later, the risk is only attached to a very small piece of performance-based incentive payment. The Maryland Primary Care Program is designed to be an advanced alternative payment program for qualified providers and to take advantage of the macro bonus as well as the other financial and support features of the program. Now let's spend a few minutes looking at the recent past and the future for healthcare delivery and payment, such as it is in Maryland. Maryland hospitals have functioned under the Health Services Cost Review Commission as an all-payer system for almost 4 decades now. In 2014, the state entered into a new model contract, with phase 1 being the conversion of hospitals from a fee-for-service environment to global budget. In 2019, the next phase of this contract calls on the state and hospitals to focus on population health and take on greater responsibilities for the costs of care. It is apparent to all the interested parties in the state that population health and costs cannot be best managed by hospitals alone, and that the resources of all providers and all elements of the state and the healthcare system must work collaboratively to find success. We find ourselves now in 2017 on the verge of a new era in which we pay for and deliver healthcare in Maryland. Let's look at the plan discussion on this slide. The first section is a hospital model which began in earnest in 2014 and will continue on at least through 2029. That model is focused on reducing unnecessary readmissions and unnecessary hospital utilization, reducing hospital-based complications, and increasing appropriate care outside of the hospital. This is really shifting the focus from the high-cost, high-intensity care that's delivered in hospitals and putting more emphasis on preventive care and shortening the hospital's length of stay where it's appropriate by bringing patients when they can back to ambulatory care for their post-hospital care, and avoiding unnecessary hospitalization and avoiding unnecessary emergency department admissions. This model will continue through 2029, moving toward a total cost of care model for hospitals and toward a population-based health metric. Also see that beginning in 2017, the Health Services Cost Review Commission care redesign programs went into effect with a focus on reducing unnecessary lab tests and increasing communications between hospitals and community providers, and increasing complex care and care coordination for high-risk and rising-risk patients, while improving the efficiency of care within the hospital settings. These are all programs that have begun in 2017 and will continue to grow through the duration of the program. These are really innovative programs designed both by hospitals and by hospital providers and non-hospital providers to achieve all of the stated goals in transforming healthcare. Then beginning in 2018, we see the Maryland Primary Care Program, which will have its first phase in 2018 and continue the initial phase from 2018 to 2023, and then continue in its second phase through 2029. And assuming success, will become the embedded way that we deliver care and pay for care in the state of Maryland. This program is focused on increasing preventive care to lower total cost of care, decreasing hospital avoidable utilization, decreasing unnecessary emergency department visits, and most importantly, to increase care coordination and the community support for non-medical and social determinants of health. The program recognizes the fundamental importance of advanced primary care as a foundation for a strong healthcare delivery system. The program also adds key resources as they're needed, including for behavioral health, pharmacy, community health workers, and other non-traditional resources in the delivery of primary care. In this slide, we describe the overall population health transformation vision under the Maryland Primary Care Program and demonstrates the trajectory over time. This begins with advanced primary care practices as a centerpiece, working together with care transformation organizations, of which you will hear much more about later in this webinar, working together with the state and community programs to build a strong foundation, moving forward and expanding the scope and numbers of care managers, community health workers, and others, all focused on improving healthcare outcomes, reducing unnecessary utilization, and supported by advanced health information technology through CRISP and other sources, and measuring performance based on data that is driving toward achievable goals. Putting all these pieces together into a coordinated healthcare delivery system and moving toward the ultimate goals for all Marylanders of a better health, better experience of care, and lower costs. Among the intermediate goals are the reduction in avoidable utilization, reducing medical complications, and delivering equitable health care to all. The primary care program exists as a distinct contract element in the total cost of care contract with the federal government. We anticipate the program will be cleared and approved by the federal government before the end of this year, giving Maryland Primary Care Program recognition as a CMS-approved program. At that point, CMMI will issue a request for applications from both practices and the aforementioned care transformation organization. The selection for those practices will be done by CMMI with support and participation by the state in the selection process. And once selected, both practices and care transformation organizations will be asked to sign participation agreements for the program. You may be aware that CMMI, or the Center for Medicare and Medicaid Innovation, created a program called the Comprehensive Primary Care Plus program that began in earnest in 2017 in many markets around the country. Our Maryland Primary Care Program is built on the framework of that program, but differs in several key ways that I'd like to highlight now. First is that the integration with other state efforts. The CPC Plus program, as it exists elsewhere, is an independent model and is not integrated with overall state initiatives. Our Maryland Primary Care Program model is integrated with the total cost of care model and with other initiatives that the state is bringing forth. Second, the enrollment for CPC Plus had an initial rollout at a cap of 5,000 practices nationally. We have no limit to practices except they must meet program qualifications. It is our hope and intention to make this available to as many practices and as many providers within the state of Maryland who are qualified and are willing to join the program. Next, in the CPC Plus program, there was a one-time application for the 5-year program. But in our program, there's an annual application period starting in 2018 and then each year thereafter. So the practices that are not enrolled in the first application period are still available for the second, third, and fourth, et cetera. Also, in the CPC Plus program, there are 2 tracks, a track 1 and a track 2. There are also track 1 and track 2 in the Maryland Primary Care Program. However, in the CPC Plus, practices would choose to be either in track 1 or track 2, and they stay in those practices. In the Maryland practice, they begin in track 1, and then they're encouraged to go to track 2 by the end of 3 years. Also, in terms of overall support for the programs, in the CPC Plus program, the support is gained from the financial incentives that are provided in the program and the learning network that's afforded to the practices in that program. In our state program, we've included both the payment redesign, the learning network, and our very innovative care transformation organization, which again you'll hear about in more detail later. Last, the CPC Plus is designed to be a multi-payer program, and in fact there's 61 payers that are partnering around the country in that program. Our program begins with Medicare and the dual eligibles, but is wide open, and we're inviting other payers to join. We anticipate that they will over the course of the program. So why don't we pause here? I've said a lot, and see if there are any questions from the audience. If there are none at this time, we'll also have ample opportunity at the end of the program for additional questions.
So, good afternoon, everyone. Dr. Haff, there's a question, and the first question is centered around the impact of practice not participating in the program.
So thank you very much. It's an excellent question. So practices that don't participate in the program will have no negative impact. They will be asked, as all practices that participate in Medicare, to choose to be in MIPS or in another APM, such as are available. We're not aware of any others in the state of Maryland at this time, so they would be.
So we know there's a little bit of technical difficulties right now. We are trying to pull up the slides. What we might have to do is actually send out the slides via email. So we will send those out shortly. Right now, we're just going to continue to go through the presentation. Thank you.
And our next question centers around the impact of practices if they fail any of the program requirements.
Thank you. That's also an excellent question. The practices who are entered into the program will have a series of hurdles to meet as they move through the progression to be an advanced primary care practice. They'll either be given support to meet those, both from the state and from the federal government in learning networks, and given every opportunity to meet all of the practice requirements. If, however, they don't meet the practice requirements, they'll be asked to leave the program. It's our intention to provide such ample support that we do not want to see any practices fail to meet the program requirements.
Yeah, we will address more questions later on in the presentation. So you see more coming up, so we'll be sure to address those if not in advance.
Great. All right, so let's go into some of the program components. Again, if I can ask everyone to make sure their mute is on. For some reason, not every phone is being muted. We'd appreciate it. So, again, this is Chad Perman. So we want to talk a little bit about the program design. The program is composed of two important areas to drive, and that is delivery redesign and payment redesign. So if we go into what are the primary care functions, we'll be starting with access and continuity. Before I jump into that, let me talk through what the following slides look like. So the current list of care transformation requirements for the program, there are 5 of them, and that is practices will be asked about their capabilities in these areas when they apply to participate in the program, and that is through the 5 primary care functions or domains. And then within those 5 domains, there are specific care transformation requirements that practices must demonstrate compliance of meeting along the way. The 5 functions or 5 areas that practices will need to demonstrate competence in are access and continuity, care management, comprehensiveness and coordination, patient and caregiver engagement, plan care, and population health. We're about to talk about the first one, which is access and continuity. Before I start with that, as noted earlier, the Maryland program is based on the CMS model, CBC+. As such, it has 2 tracks, track 1 and track 2. The second track is the more advanced track that a practice would show its transformation level. So, and in each slide that we show you going forward, we display the track 1 requirements and then the track 2 requirements. The track 2 requirements are above and beyond the track 1. So a track 2 practice would be expected to show both the track 1 and the track 2 requirements. So if we look at the access and continuity domain, a practice would be expected to address a patient's coverage by a care team and access to his or her health information. Some of the requirements include empanelment. So are you taking responsibility in assigning patients to a care team being a group of individuals at your practice led by a practitioner who work together to care for a specific panel of patients. The care team should also be providing 24/7 coverage, including access to electronic health records. And then when you move to track 2, it would include those But also for track 2, do you have alternative visits such as e-visits or group visits, telehealth, remote monitoring, or that level of care for your patient? Then we move into care management. So care management, there's a large focus on care management in the Maryland Primary Care Program. All practices must identify and prioritize a methodology to risk stratify their impaneled patients. So a question that practices should be asking themselves is, do you have an algorithm for this, or what kind of tool are you using to risk stratify your patients? Practices should also be providing longitudinal care management for those who are identified as needing of intensive, ongoing relationship-based care for patients at the highest risk for adverse preventable outcomes. Practices would also be providing episodic care management that is short-term, goal-directed care for the patients who are not already targeted for the longitudinal care management. And also appropriate care, contact and follow-up for patients having been seen in the ED or hospital. For track 2 of care management, it would include an above level of risk stratification, so what is called two-step risk stratification. So in addition to using an algorithm that's based on claims or diagnoses, the practice would be expected to be adding their clinical intuition to the risk stratification. In addition, a practice would be expected to develop and use a care plan with the patient that is based on the patient's goals and available medical evidence and is accessible to all team members providing care for the patient. The third domain is comprehensiveness and coordination. This set of requirements is about the ability of the practice to address the majority of needs of your patients and coordinate services with other providers. Practices would also identify the high volume or high cost specialists and healthcare organizations using payer data. Practices would also assess the extent to which your practice communicates and coordinates with hospitals and EDs. For example, how do you get data in a timely fashion from hospitals and then coordinate care with hospitals? At the track 2 level, practices would be identifying high volume or high cost specialists and also establish formal care compacts or collaborative agreements with these organizations. Practices would also be expected to be addressing social needs. So are you assessing patient needs today, and do you have a resource inventory to then address social needs that you identify? Practices would also be expected to be integrating behavioral health to their practice, and there are several options that practices are given for selecting and then addressing behavioral health. Practices would also identify the needs of subpopulations and develop tools to address these patients, especially high-risk patients. The fourth primary care function is patient and caregiver engagement. Practices would be expected to convene a Patient Family Advisory Council, or a PFAC. In track 1, that would be expected to be done at least once per year. Practices would also assess practices' capabilities on self-management for patients. When practices are in track 2, it would be expected to convene the PFAC in at least quarters. When it comes to self-management, practices would be expected to implement self-management support for at least 3 high-cost and high-risk conditions. For the fifth domain, plan care and population health, these requirements are around using data to plan care and using data to perform quality improvement in your practice. So in track 2, there's a requirement for regular care team meetings to refine these tactics. Let's take a pause for a second here and see if there's any questions.
Yes, thank you, Chad. We do have a question from the group. Track 1 MS at ACO that also participate in the Maryland program still eligible for the 5%.
One, Medicare Shared Savings participants, ACO participants who are also in the Maryland Primary Care Program are eligible to participate in the program. Macro qualification would be determined by their ACO participation. Maryland Shared Savings ACOs at the track 1 level is not considered a risk-sharing downside risk program. and thus would not be considered macro qualified based on the current rules. Practice would have to be only in the Maryland Primary Care Program potentially to be qualified for MACRA as a potential rules coming out, or be in a risk-sharing ACO or a Track 3 ACO.
And we have another question. So our next question comes from a student that would like to know the frequency of program requirements.
So program requirement changes will be established by CMS. The state will work with CMS to establish those. Program requirement changes are expected to be established on an annual basis.
Thank you. That's all the questions.
Thank you, David. So, in addition to the 5 primary care functions and the care transformation requirements, practices will also have quality and utilization metrics that they will be measured by. There are 2 main components to the quality and utilization metrics. The quality metrics, there are 18 of them. Practices must successfully report 9 of the 18 measures. There are proposed measures now for the 2018 measure period for CPC Plus. The Maryland program plans to use the CPC Plus measures on the quality side. Practices must report both measures that are in the outcome set, so that's Group 1. In Group 2, those are process measures, so practices have to report at least 7 of the remaining 16 measures in there. And you can see on your screen the remaining categories of where the process measures are: cancer, diabetes, care coordination, mental illness, behavioral health, substance abuse, safety, infectious disease, cardiovascular disease. And these measures are very similar to the 2017 CPC Plus measures and largely align with Medicare Shared Savings ACO measures. In addition, there are utilization measures that are specific to total cost of care, compensation, and they are based on Medicare fee-for-service beneficiaries. So we have the requirements for the program, but we have, so let's talk about the payment incentives and the payment redesign. Track 1 and Track 2. We have 3 streams for practices. 2 of those are prospective in Track 1. The first and the largest and maybe the most significant for population health management is the risk-adjusted care management fee. The care management fee is intended to support augmented staffing and training related to non-visit-based and historically non-billable services. These include activities to improve care coordination, implement data-driven quality improvement, and enhance targeted support to patients identified as high risk. These are care management dollars for all attributed Medicare fee-for-service beneficiaries in your practice. The care management payments are designed to allow practices to address the varied needs of Medicare and embed resources necessary to manage the health of the entire population. It is important to note it's akin to the chronic care management fee that is currently billable in CMF. As such, practices cannot bill both. The CMF is a prospective payment that covers all beneficiaries, allowing greater flexibility for the practice to organize its resources to address the needs of its care management fee. Track 1 on average is $20. In a range, it's per beneficiary per month, and it's a range between $6 and $50 per beneficiary per month. The highest tier of that for $50 covers complex patients. Based incentive payment, that's a combination of your quality and utilization metrics. So in Track 1, there's a $2.50 payment opportunity. It's half of that is the quality side, half of that is your utilization metrics. That's also paid prospectively. It's paid prospectively on an annual basis, so you're paid at the very beginning of the program year, and then reconciled at the end of the year to see how you compared to the benchmark. And finally, the underlying payment structure for the program. For Track 1, it's standard fee-for-service Medicare, and that's paid through regular fee-for-service claim payments. Moving to Track 2, same payment streams for practices, but at a higher level. So you can see in the care management fee, on average, $28 is expected. Of course, these average payments depend on the acuity of your population. The range is between $9 and $100 per beneficiary per month. again, paid prospectively. The performance-based incentive payment, $4 per beneficiary per month, again, paid prospectively but on an annual basis. The difference in Track 2 really comes down, and the major change is in the payment structure. So practices are expected to accept a hybrid payment called a comprehensive primary care payment. So CMS will use a hybrid payment that will allow practices flexibility to deliver care. And this upfront CPCP component of the hybrid payment compensates the practitioner for transitioning clinical services that have traditionally been separately billable office visit E&Ms to commonly non-billable care delivery modalities such as telephone calls or secure messaging. Practices are given several options to choose from. The practices must accept a percentage of their historical E&M revenues upfront and then bill the remainder as fee-for-service. Practices will be given options to choose from. The first year you have 4 options to choose from. The second year you have 3 options to choose from. And then for the third year out that you're in Track 2, practices are given 2 options to choose from. And CPCP is meant to allow practices to innovate, to redesign how they provide care for their patient panel. So let me stop here for a second as we walk through the payment streams and again pause for any questions.
Thank you. Questions from the group came to, can you talk a little bit about the differences in the amount of work in Track 1 and Track 2 that are very similar in nature?
Yeah, so I think that the progression is really a smooth progression from Track 1 to Track 2. There are some things in terms of the having a patient advisory committee that would be more advanced. There's some more intensity in terms of the way that patients are stratified, risk stratified within your practice. And most importantly, I think the big difference is for practices to be able to learn how to work within the comprehensive primary care payment strategy so that they're getting, in essence, prepaid for the services that they provide, freeing them then up to do more innovative kinds of things in terms of telemedicine and group visits that may not be otherwise compensated under Medicare fee-for-service payment system. So I think it's really it's more a gradation and a change in the way that the Medicare payments are made.
So our next question centers around the comprehensive primary care payment, and the group would like to know a bit more about how practices move along the scale, what are the requirements, and what happens if they don't progress along.
So practices for the comprehensive payment are given in the first year that they're in the Track 2 level are given 4 options. They range from a split of taking 10% of your comprehensive payment and 90% of it in regular fee-for-service, all the way to 65% in comprehensive payment and 35% in your fee-for-service. By the third year of being in Track 2, and again, you could start in Track 1 and then move to Track 2. By the third year of being in Track 2, you only have 2 options, and I believe they're 40% and 65% of your prepayment. Practices would have to move to that comprehensive payment. Practices, that is part of one of the requirements of being in Track 2 and being in the program. Practices will be supported by a learning system in the program and how to take that on. And practices, it will be one of the expectations in order to stay into the program.
And our last question for the moment is around documentation. It reads, is there a more recent comprehensive primary care redesign proposal than the one dated December 29th, 2016?
That outlines the program requirements.
That is the current one that we have up. We are working on putting an updated program proposal and program summary on the website. So thank you for bearing with us.
That's it for the moment.
Great. So we're going to move past payments now and talk about a few more supports to practices that we want to ensure that are there. A very important support and something that is unique to the Maryland program is something that Dr. Haff referred to earlier, which is the Care Transformation Organization, or the CTO. This is something that doesn't exist in the federal model. but is an innovation to the Maryland design to assist practices in meeting the care transformation requirements. The CTOs provide services in 5 main areas, and those are on the left side of your screen. So care management staffing, comprehensive care coordination, data analytics and informatics, social services connection, and practice transformation technical assistance. The focus for the care transformation organization is largely on extending resources to practices that may be hard for practices to either employ or coordinate otherwise, such as care managers, community health workers, social workers, pharmacists, behavioral health,
I'm just doing my notes.
Nutritionists, and other supports. We've listed a few of them in the section on the right of the screen. CTO is an option for practices, but it's not a requirement for them to use, but we believe a lot of practices will have a need for this support in order to meet the requirements in the program. At this point, I want to stop again to talk to field a few questions.
Thank you. So the first question on this slide from the group pertains to packages. How many should be offered minimally of the services provided to a practice by a CTO?
So in terms of packages for the CTO, this is a process that we've been trying to work through and understand what are the supports that a practice needs, and how might they share their resources with a CTO in terms of financial resources to support the infusion of this. I don't know that we have a final answer at this point, and we're looking for feedback to conclude this part of the design of the program.
Our next question.
I can learn to understand you much better if I can get familiar with the way you talk. I need your permission to help. I can learn to understand you much better if I can get familiar with the way you talk. I need your permission to help. I can learn to understand you much better if I can get familiar.
Thank you.
So, yes, practices can annually change their CTO, and in terms of the bundle of services that the CTOs provide, those would be elected by the practice. So the practice would decide from the CTO what services they need, and would be sharing care management fees proportionately.
Dr. Hass, the next question to follow along on this particular slide states, assuming that a Track 1 MSSP CTO can meet the operational requirements to be a CTO, are required to be established, or is that at the discretion of the ACO?
That would be ultimately at the discretion of the federal government and CMS, but we anticipate that as long as the entity meets the requirements for a CTO, that they wouldn't need to establish a separate legal entity.
Dr. Hassel, the last question on this slide comes from the group wanting to know how will CTOs be evaluated?
CTOs will be measured on quality metrics, utilization, and their abilities to support the practices that they are engaged with.
That's all the questions we have for the moment.
Great. Thank you. Back to the presentation. Another important area of the program is supports to the practices in terms of health IT and data. CRISP is going to be an integral part of the success of the primary care program. We know many of the practices out there are already connected and using CRISP every day. Connectivity and data exchange are simply a vital component of care transformation that we want to ensure are part of the transformation here in Maryland. CRISP is partnering with us to make sure practices who need this support can get connected, including paying incentives to providers to connect and exchange clinical data. Currently, CRISP is operating a program called the Data Exchange Support Program, or DESP. We want to make sure that practices have access to that. Practices who are not fully connected to CRISP and exchanging clinical data have an option to connect up to that so they can operate fully in the program. Being connected to CRISP is going to be a requirement of the program, and using their quality reporting system called Caliper to report measures is also going to be a requirement. So using CRISP opportunities to connect up. We want to make sure that those are fully available to practices. On the right side, we also list out key services for practices. Many of you are very familiar with these and hopefully are using them. So the prescription drug monitoring program, the encounter notification services, CRIS query portable, and direct secure messaging are among just a few of their important services. These services are going to be available to practices and integrated for practices as well. And we expect that practices will leverage these to meet the care transformation requirements. I'm going to continue to move through here because I believe
I think we covered, yeah.
Yep, I think we've hit some of these questions. Let me move, we'll go into the next section on next steps. So let's review for a second the timeline going forward, and then we'll come back to additional questions and answers. So as of now, we have submitted the overall total cost of care all-payer model for approval with CMS and the Department of Health and Human Services. That is going through an approval process now. We have also stood up a program management office here at the Maryland Department of Health. That's a small group here to assist the state and CMS with implementing the program and making sure that it fits the needs of Maryland. We're also working on developing legal agreements and the applications for the program with CMS. We anticipate releasing an RFA or request for application sometime at the end of the year or the beginning of 2018. And then following that, we would select both the care transformation organizations and the practices sometime in early 2018. The application for the program will be a combined application for both the care transformation organizations and the practices. If you're familiar with the CPC Plus application, you'll recall that it was a combined application for payers and practices. This one will be a combined application for CTOs and practices. And then we expect the program to launch in the summer of 2018. Let's stop here for a minute for questions.
So thank you. The first question comes from someone that wants to know whether they will be, it reads, will we know our acceptance in the in the program before the MSSP ACO determination?
I believe we will not know acceptance into the program before the ACO determination because I believe that's the end of the calendar year. And so the acceptance into the program, we will not be able to likely get applications out for the program until end of 2017, early 2018. So, and practices won't be selected sometime until winter or spring of 2018.
Our next question comes from someone who wants to know what guidance the department can provide practices as they think through the complicated decision.
So we're happy to assist with any technical decision-making we can. Ultimately, it will be a decision that practices have to make, I think, based on their own trajectory for healthcare, how they want to provide healthcare, and financial considerations and other things that may be important to them. But we're certainly here willing and able to provide whatever technical assistance we can in terms of answering questions about the program.
Dr. Haff, we have another question that reads, what is the maximum portion of the care management fee that a provider may pay/share with a PTO?
50%.
And then the next question along those lines, how many care managers does a practice need to have?
So there is no set number of care managers or ratio to provider to care manager or number of patients. I think that's something that is sort of put in the parlance of a sufficient quantity. So a practice that has a large number of high-risk patients may need to have more care managers. One that has a lower number and more preventive care may need a smaller number. Also, the kind of care managers may change from practice to practice. Some may be more involved with transitions of care, and some others may be more involved with preventive care or other kinds of aspects. So I think that is, there's not a hard and fast on that. just a sufficient number.
And our next question centers around reporting requirements for practices. Can you discuss briefly what practices you expect around reporting?
So practices will have a few different areas of reporting. First of all, they will be expected to report quality metrics. We talked a little bit through the electronic clinical quality measures that they will be expected to report. Practices will also be expected to submit a budget at the beginning of the program year to show how they anticipate using their care management funds. Practices will also be asked to fill out a quarterly survey to CMS that will show them and answer questions about where they are in terms of their care transformation requirements or their milestones. How are they doing? So those are the main areas of requirements in terms of reporting that a practice will be expected to hit.
I have two more questions in the queue. The first one is if a physician retires or leaves the practice, are they eligible for the macro bonus in 2 years?
I don't know if we have an answer to that question about whether they retire.
Yeah, I would, in general, I would refer all the macro questions, the specificity of that to the qualified provider sections that CMS publishes. There are a number of sometimes complicated rules on that in terms of reporting periods and payments. So rather than give you an incorrect answer, I would refer you back to the CMS website.
And the next question reads, will CMMI or the department provide direction or rules that outline service levels and a fee structure between 0 and 50%, or is it up to the CTO to set those?
Yeah, we expect that CMS will be defining the menu of options, includes the service levels and the revenue share between a practice and a CTO should they decide to use a CTO.
Another question is on attribution. If the number of attributed patients fluctuates during the year, does that put the practice at risk for participation?
So this is it's a prospective attribution, so that the number that you have attributed at the beginning of the year would be your number for the year. It would be adjusted on an annual basis. If it falls, however, below the reasonable number that per tax ID, then I think, or the hurdle number, then it may trigger some action.
The next question centers around the learning system, and would wonder if the question is, can you provide a bit more of an overview about what to expect in the learning system?
For the learning system, CMS will operate the learning system. We expect that it will look similar to what they have been doing with CPC Plus, and that is to support practices through both materials and in-person activities, as well as electronic supports such as webinars, hopefully without as much noise as our webinars, and as well as newsletters. They will also be doing assessment and feedback efforts. So CMS is building that. They already have had a year under the CPC Plus program, and then we'll plan on rolling out a Maryland-specific learning system to support practices, which is really designed to ensure practices can meet the care transformation requirements and continue to transform and can move through the program to the Track 2 level and be successful.
So I have an interesting question that we may need to get back to them on, and that is if CMS or ONCC certifies an EHR that was certified and included in the program, what impact does that have on the practice?
I think that we'll have to get back on that question, but our focus is not so much on the fact that EHRs are certified, just that they're capable of working within the parameters of sharing information. So I think it would be an unusual circumstance that if an EHR is able to meet all the other requirements of the program, that they would become decertified. But I think that is a low probability, and we'll have to get a better technical answer.
Very good.
Right. I believe we have another slide that actually goes to a little bit of the question about guidelines and guiding practices and thinking. This is really more about process, not around specific answers, which is not for us to say anyways. But we wanted to give some thought and share our general considerations for participation for practices. So going from left to right, this is, again, considering our timeline that we're thinking through, highlight the need for practices to prepare now and think through their business and partnerships. Assessing the financial opportunity and your practice capabilities, and also your organizational priorities. Does this fit within that? We've also provided links, and we will be sharing this presentation afterwards for the CPC Plus RFA and the FAQs. Given that the program is based on the CPC Plus program, it'd be useful, I believe, to review those at this point to get a sense for what the RFA might look like and what the FAQs generally of the program are. We are going to continue to hold meetings and webinars similar to this and with more details, so we hope that you'll continue to join us. As we get farther later into the year and into the winter of 2018, like I said, we hope to have an application released. It's at that point where you'll want to begin to assess whether a CTO might make sense for you. We expect that CTOs will be chosen first, so into the beginning of 2018, once CTOs are submit their applications and then are chosen, practices would then have the option to review what their CTO options are. And practices probably can begin to think about what might make sense for them anyways. And again, we'll continue to have meetings throughout the winter. And then later in the winter and into the spring, we hope that practices will have seriously considered the opportunity and will choose to apply for the program. At this point, we have finished going through all of our slides. Thank you for bearing with us. And we have a few questions we'd like to field and then open it up for additional questions and answers.
So the next question centers around the requirements on CTOs to accept all practices into the program.
Yes, so CTO would be any practice that would choose a CTO, they would be required to accept that practice as long as the practice is performing and a bona fide member of the program.
And Dr. Hass, the next question is what are the parameters the state will use to decide if the program is successful or not?
So that's a very good question. And number one, the program is sponsored by the Center for Medicare and Medicaid Innovation. And as in all their programs, they will be doing an independent evaluation to see if the program meets the test under the waiver that they exist under, which requires all investments that they make to either improve quality or lower the cost of care, or some combination of the two of those. So it could increase quality without decreasing the cost of care, increase quality with an increase in cost of care, could decrease cost of care without any change in quality. It would all qualify. The state will independently also be looking to see how well this fits into the future of healthcare fabric in the state. It's our anticipation that doing the things that are sketched out in this program, providing better coordinated care, providing more person-centered care, employing health information technology to make more efficient care, attending to the non-medical or social determinants of health, employing more pharmacy services and resources in the care of complex patients, working on transitions of care. All those things are things that the state embraces as the proper way to improve health care for the future. So I think if we're successful in this, that it will be incorporated as the way forward for the state.
Dr. Hass, the next question centers around the cost of a practice to complete the application and the analytical assessment for the impact to know whether or not that they'll be accepted into the program. What does that cost in terms of time and human resources?
There's no monetary cost for it. The cost would really depend on the complexity of the practice. It's not intended to be overwhelmingly detailed in terms of the application process. So it should not be, I would say, compared to the overall program, it would be a negligible cost.
And our last question for the moment is regarding whether or not, where does individuals go after the conclusion of the webinar to learn more about the program or ask specific questions?
So we should have the website on the second to last slide, I believe, for the screen. I think it may not be up at the moment. So when we send out the slides, we have a website up at the Maryland Department of Health for the primary care program that everyone can follow. We'll have updates for the program, and we will continue to post, and we will also share the slides going forward for everyone to be following along. One other update that I'll provide, hopefully many of you have received this and will also be receiving it, I know, through the Academy and the college, is that we are going to be doing regional provider meetings starting in late November and into December. So we'll be doing meetings around the state in the 4 regions, and those meetings are going to be coming up starting, I believe, November 29th and run all the way into the end of December. So, and those will be in-person meetings, and we can get a little farther into the details of the program. So look out for a message on those dates. I know Dr. Zapp and Dr. Sisson are going to be sharing those dates with you as well.
Our next question, as they continue to come in, relates to FQHCs and their eligibility to participate in the program.
At this time, FQHCs cannot participate in the program, although we continue to have discussions with the federal government and HRSA regarding the possibility of including them in the second year.
The next question regards movement through the track. Could someone talk a little bit about the progression and how you go about moving between track 1 and track 2?
So practices are required to, by the end of the 3rd year, move to track 2 from track 1. Practices could be in track 2 straight out of the block, or can also proceed to track 2 earlier in the program. And that is a question of whether practices are able to fulfill the care transformation requirements of track 1 for the end of their 3rd year, and their willingness to accept the comprehensive primary care payment.
Chad, are payments to practices in the program likely to increase at any point in time?
Anything's possible. We don't determine the payments. Those are up to CMS. All payments come from CMS as well. No payments go through the state. I believe the macro payments, are subject, I believe at 2025 or something like that for an increase overall. So all of that is really up to the federal government as well as far as payment levels.
So the next question takes us back to the 12/29/16 document on the program. In the original document, there was only one care management fee payment with an average of $28, and now there's a second model. The requester asked for more information about the change in design.
But simply, as we went through the process over the last year of working with our federal partners, there were a number of small and sometimes a little larger than small changes that were made from the original design to the current design. We feel fairly confident that the current design is the design that will be approved before the end of the year by the federal government. The change from the single care management fee in both tracks to the bifurcated one was based on information provided to us from the federal government.
So, Dr. Hass, that concludes, we do have one other question. It reads, if a provider picks the CTO and the dollars are due to the CTO is paid by the provider